Well, welcome everybody. Happy Friday, the best day of the week. And no, not because it's the weekend, because it's Grand Rounds Day. You have logged on to Grand Rounds, presented by the Department of Psychiatry and Behavioral Sciences. Of course, you all know that already, but did you know that today's presentation is sponsored by the Garvey Institute for Brain Health Solutions? And as you can see, we have a lot of guests here today. We've got a big panel. So I am going to make my introduction as fast as I possibly can so we can get through some of our other introductions. A few logistics about our Grand Rounds series before we begin. First of all, we're recording this today. It's recording right now. You probably heard the message. So we will be putting this on our Grand Rounds archive that will show up this afternoon or sometime on Monday. So if you'd like to watch it again, it will be there. It's available. We also have a survey that will be available at the end. So if you'd like to provide any feedback about today's presentation, as soon as the webinar closes, you'll see a link. So go ahead, click that link. We'd love to hear your feedback. If we have time, we'll do some Q&A at the end. So if you have any questions that come up during the presentation, go ahead, type those into the Q&A. I'll queue those up, and we'll try to get through some of those if we have time. And I just want to let you know that next week, we have another Grand Rounds at noon, another also on Friday, and that will be with Dr. Marketa Wills, and she is the CEO of the American Psychiatric Association. So please join us for that one. That will be great. And I think with that, I am going to pass the baton over to the chair of our department, Dr. Jürgen Unitzer, who's going to do our next introduction. So Jürgen, how about over to you now?
All right. Thank you, Jed. Welcome, everybody, to today's Grand Rounds in Psychiatry and Behavioral Sciences. So today, as Jed said, we're in for a real treat. We will have a set of presentations from our own trainees and some of our faculty who have been supported by our new Clinician Scientist Training Program. And before I do anything else, I'm going to thank our presenters. I want to thank our faculty mentors, and I also want to thank Andy Iwamoto and Jesse Fan, who support our Clinician Scientist Training Program. So one of the things I most appreciated when I came to UW as a fellow some 30 years ago is the fact that not only did I get good clinical training, but I got a chance to work with some clinician scientists who were not just doing clinical care, but they were really thinking about what does better care look like in the future. So for example, I had the opportunity as a fellow some 30 years ago to provide telemedicine services to a small clinic in rural eastern Idaho. And that was some 20 to 25 years before anyone else had ever thought about really doing telehealth. And so that was really exciting for me. It was sort of like today, that's everybody, that's normal. That's how we do outpatient psychiatric care. But 30 years ago, it was sort of like back to the future kind of stuff, very, very far out. And I think when we can offer those kinds of opportunities to our residents, the opportunity to learn from good clinicians and teachers, but also to work in a setting where we have faculty doing research that really thinks about how does better care look like in the future, that's a very powerful offering. And that's really the goal we have for our new departmental clinician scientist training program. And we are very fortunate here, I think, to have Jesse Fan as the leader for this program. Jesse is an accomplished clinician scientist in our department who leads this new initiative. And I think he might tell us a little bit more about CSTP. But before he does that, I'm going to say just a few things about Jesse. So Dr. Fan trained as an engineer at Stanford and did his medical training at Northwestern before he joined us here at UW for residency and fellowship. And as a fellow, he got additional training in research, getting a master's in public health in epidemiology, and did some really good work with Wayne Caton and other senior mentors to really develop as a clinician scientist. And that, I think, has helped him go on to have a really remarkable career as a clinician scientist doing high impact work in psycho-oncology and neuropsychiatry and head injury research. And today, Jesse is an endowed professor in our department. He still provides great patient care for our patients at Fred Hutch. He leads our program in psycho-oncology there. He continues to lead and partner in clinical and health services research, and he's mentored and taught scores of students, residents, and fellows along the way. I think Jesse is a wonderful example of what a career as a clinician scientist can look like, and we're really fortunate to have him leading this program. So with that, Jesse, I'm going to turn it over to you, and I'll let you introduce today's program and our speakers. Thank you.
Thank you so much, Dr. Unutzer. It's really a privilege to be able to lead this grand rounds today and really highlight our trainee research awardees. I'd like to give you a little background first in recognition of the importance of clinician scientists as important people in terms of identifying and asking critical questions that need to be researched and answered, and then being able to translate those findings back into clinical practice. We stood up this clinician scientist research program, as Dr. Unutzer mentioned, and unfortunately, over the past several decades, we've seen a steady decline among both MDs and PhDs in terms of the number of people going into research. And this is just one example looking at the NIH loan repayment programs, which is an indicator of people going into research. The prospect is particularly concerning for physician scientists. And these are just some examples. You see a steady decline of physicians stating that their primary professional activity is research. You see that decline over the last several decades. You see that among the relatively small percent of physicians who are engaged at all in research, the vast majority are engaged in a very small percentage of their time. You also see that among NIH-funded grants, the proportion of those grants that are won by physicians has been steady and relatively low, only 30% over the last 30 years. And when you look at career development awards, which are really critical for launching many careers, the small percent of faculty in psychiatry departments, and only 0.4% are going to psychiatrists among these career development awards. So even though a lot of medical students are saying when they enter medical school and during medical school that they're interested in research and actually participate in some research, a very small percent actually plan on going into research as a primary role in their careers. So in recognition of that, our mission at the Clinician Scientist Training Program is to develop clinician scientists by identifying, engaging, and supporting students, trainees, and early career faculty who are interested in research. And again, generously funded by the Garvey Institute, the Wayne Caton Foundation, as well as other important supporters of our department, and managed by Andy Uemoto. So our approach is multi-pronged, and I encourage you to take a look at our website. But our trainee research awards are an important part of our approach. Another important part is to try to integrate research into training more robustly, and also to help pair trainees with mentors in our department and outside our department, and also, very importantly, to incentivize and support our mentors as well. So our trainee research awards are one-year awards up to $25,000 and are eligible to psychiatry residents, psychology interns, and fellows. And they are mentored by a member of our faculty in the psychiatry department, although they may also get mentorship from outside the department. And we were very fortunate to be able to fund in our very first year 10 great studies. Here you see the awardees and their mentors. In our second year, we were able to fund 7 awardees, 7 studies, and here are their mentors as well. And we're very, very lucky and excited that this year, in our third year, we actually got 15 applicants, which is more than the first 2 years, and we're able to we'll look forward to funding a really diverse group of awardees. Here's a look at the first 17 awardees and their mentors, a very diverse group with diverse studies. And today we're going to highlight very interesting, 4 very interesting studies, very diverse, ranging from biomarkers to health services and epidemiology and cultural psychiatry to machine learning. And so I'd like to turn that over now to Dr. Hendrickson, who's going to introduce the first study by Kat Liang. Dr. Hendrickson?
Yeah, thanks. I am so delighted to introduce psychiatrist and psychiatric neuroscience researcher, Dr. Catherine Liang. Dr. Liang completed an MD PhD at the University of North Carolina, where her experiences with her mother's progressive vision loss inspired her to complete a PhD focused on the application of gene therapy to retinal physiology. As a resident here at University of Washington, she did basic research with Dr. Neumeier, exploring molecular mechanisms by which stress alters serotonergic signaling. And then she pivoted yet again for her research fellowship at the Seattle VA, where she learned to conduct human clinical trials and was able to bring all these different experiences together in projects like the one you're about to hear about. I could use her entire speaking slot trying to convey what an amazing experience it's been to serve as one of the mentors in her journey. But instead, I'll end by noting her creativity, her meticulous scientific rigor, and her commitment to using these skills to improve, broadly speaking, clinical care for patients, no matter the sometimes immense challenges thrown her way, are an ongoing inspiration to me, and I suspect many of you as well. Dr. Liang.
Thank you so much, Dr. Hendrickson, for the kind introduction, and a thank you to Dr. Fan and Dr. Initzer for the invitation to share my preliminary results from my pilot clinical trial, the BRIGHT study, for the first time to a public audience. The title of my talk is Gaze into the Future, an Eye-Brain Connection for PTSD Biomarker Development. This project arises from a high clinical need for research in PTSD treatment. So to date, there are still only 2 FDA-approved medications for post-traumatic stress disorder, sertraline and paroxetine. These are both SSRI, or serotonin selective reuptake inhibitor antidepressants. And they really have limited efficacy, but they do work really well for certain people. The trick is to figure out who they work for. If there was a quick test that we could do up front to develop a personalized medicine treatment algorithm in mental health, this could have a huge impact on alleviating burden in both for both patients and clinicians. The problem is really that the brain is the most complex organ in our body. Brain imaging is really expensive, and the brain waves that you can measure with techniques such as electroencephalogram are really difficult to measure and difficult to interpret because the brain is just so complex. As Dr. Hendrickson mentioned, before coming to psychiatry, my research background was in the eye, so I started getting this idea. What if our eyes really held the answer to what PTSD treatment was right for you? The brain, the precedent or the rationale behind this is that the brain and the eye are very closely interconnected. The brain connects to the eye connects to the brain. Electrical signals from the eye that project to the brain are interpreted by the brain as vision. And the reciprocal connections are really important too. The brain controls eye movements, controls your pupils, constriction and dilation. But is there more? As it turns out, there are actually direct inputs from serotonergic centers of the brain that project directly into the retina. And as I mentioned before, that serotonin is a PTSD drug target, with the 2 FDA-approved medications being SSRIs. Now, hold that eye-brain connection in your mind while I explore this other rationale behind this approach. So while in some ways, this idea of using a biomarker outside of the brain to predict brain biology might seem a bit far-fetched, there is precedence for peripheral biomarkers to predict treatment response in mental health. There is this heterogeneity in PTSD, so meaning not all PTSD looks the same across different people, which is part of why it's such a difficult condition to treat. A treatment that works in one person might not work for the next person, likely due to differing biology. My mentors in the department, Drs. Raskin, Hendrickson, and Peskin, showed that higher standing systolic blood pressure predicted which patients responded more robustly to the alpha-1 adrenergic receptor antagonist prazosin, likely because standing systolic blood pressure is a marker of noradrenergic tone. So there is some evidence to suggest that some patients with PTSD might have a higher noradrenergic tone driving their symptoms, whereas others might have a more serotonergic dysregulation driving their PTSD. So could we take advantage of a serotonergic biomarker to predict treatment response similar to this approach with the noradrenergic side of things? So given the serotonergic inputs to the retina that I explored in my previous slide, I wondered if these signals from the retina could be measured to reflect this differing biology and tell us who might respond better to serotonergic medications such as an SSRI antidepressant. So to tell you a little bit about how this might work, when light hits the eye, it passes through the anterior parts of the eye, the cornea, and the lens, and goes all the way to the back of the eye, the retina, which is neural tissue. And that neural tissue converts that light signal into an electrical signal that is then passed on to the brain, and the brain interprets as vision. Here's an example of an electroretinogram waveform. So you can use this device called an electroretinogram to measure the electric signals that the retina transduces to the brain. And this is what that waveform looks like. There is an A wave and a B wave. And these signals this is the general waveform that's transmitted to the brain. And so there, in fact, actually has been one study that has looked at ERG as a biomarker to predict treatment response to antidepressants in major depressive disorder. And in this study, they found that people who responded to an antidepressant, so patients with major depressive disorder whose depression got better with antidepressant treatment at baseline, here on the y-axis, we're looking at B wave amplitude. So as you can see from this waveform, the amplitude of this wave from baseline. The baseline, so before treatment with an antidepressant, their amplitude was higher in patients whose depression got better with antidepressant treatment compared to people who didn't respond. So these are people with major depressive disorder who didn't get better, and compared to healthy controls. And then you can see that after 12 weeks of treatment with an antidepressant, the amplitude decreased and normalized to look more similar to people who didn't respond and similar to healthy controls. So this study in major depressive disorder informed the design for my clinical trial looking at this concept in PTSD. So in my study, I had just enough resources. I proposed this idea, received funding from a VA seed grant to do some initial testing to see if the ERG could pick up on a short-term change to serotonergic signaling following a single dose of an SSRI. So I had just enough resources to do this as a single-arm, single-visit pilot trial where we did initial mental health measures followed by an in-person electroretinogram, a single dose of an SSRI, and a follow-up ERG, just to see if we could pick up any perturbation of the serotonergic system. And then the Garvey CSTP award actually allowed me to add on this follow-up study arm where those initiating any serotonergic antidepressant through care as usual through their psychiatrist or primary care physician were invited back for follow-up, and following mental health measures are collected, as well as a follow-up ERG. So I am still actively recruiting for this clinical trial. If you have any patients who with PTSD who might be interested in participating, please send them my way. I have a direct link here for that goes to a pre-screen. Patients who qualify will be contacted by us. So would love to get help in recruiting for this. Here I'll show preliminary results from the first few participants of this trial. So here is an example of an ERG waveform that I collected from one of the participants. This is raw data. So on the y-axis again is the B wave or the amplitude, with the B wave being the second waveform here, both pre and post SSRI. And so you can see with my study design, so first ERG before and second ERG after SSRI. With my study design, I reasoned that if I saw a signal, that this would be good evidence to support further testing. So remember that based on previous studies, I expected the B wave amplitude to be higher before SSRI treatment and to come down with treatment, with a bigger decrease in the amplitude in patients who are more likely to respond to an antidepressant. In my preliminary data, I was able to so far collect data from 4 participants. Again, on the y-axis, B wave amplitude here with the different colors here representing data from 4 different patients, and the individual data points that are the same color representing data points from the 2 different eyes from each patient. And you can see that there's a general trend downward that was statistically significant with a paired t-test. You know, because this is a short time point after a single dose of an SSRI, this doesn't tell us anything about clinical treatment response. But I did reason that this overall downward trend of the B wave amplitude from pre to post SSRI, this would suggest that there is a real biological signal that we're picking up on related to the SSRI, which is evidence to suggest promise for further testing. So next steps, so far we've enrolled 5 participants now. And actually one of our participants meets criteria now for a follow-up visit. So stay tuned for further results from this trial. And the big hope is that the pilot data from this grant will lead to further research grants, larger grants to fund larger clinical trials where I'll actually be able to look at more mental health outcomes to further develop this technology in a mental health setting. Has a huge potential impact on the field, in personalized medicine. If we can further this type of technology, we could optimize the use of medications we currently have. We could increase knowledge of biological mechanisms even beyond PTSD and develop new treatments, reduce patient suffering, family burden, physician burden, and burnout, as well as healthcare costs. We can really optimize the efficiency of assigning treatments that'll work up front. Then we could reduce patient suffering, family burden, and improve patient satisfaction and health outcomes. And all of these things are important building blocks that I hope will further my career as a physician scientist. So with that, I'd like to acknowledge everyone who contributed to the success of this study so far. Everybody likes to acknowledge their parents, but as Dr. Hendrickson mentioned, my mom really has been the inspiration for this study. I can't my whole medical career was really informed by my mom, who's blind. And even when I decided to go into psychiatry instead of ophthalmology, my background and interest in the eye has sustained me. So this project is really a product of that personal connection. I could not have gone anywhere with this project without my primary mentor, Rebecca Hendrickson, who Dr. Hendrickson really believed in, this study, even when, a lot of folks at this early stage career thought that this was a bit of a high risk, high reward project for someone so early. So I do really appreciate her support in making this happen, as well as members of the lab for really helping me through the logistics of the study, as well as my MyRec mentors, Dr. Raskind, especially as well, financial support, VA seed grant, as well as, of course, the CSTP Garvey Institute Award and other supports to my career development. Thank you so much.
Thank you so much, Dr. Liang. I don't see Dr. Thielke here. I will go ahead and introduce Dr. Minnie Jacob, who will present her next study. Dr. Jacob.
Thank you, Jesse. Good afternoon, everyone. I will be presenting my study that examined 2 risk factors for depression among an immigrant population. And the risk factors that I examined were acculturation and discrimination. And the population of interest is the older Asian Indian immigrant population in the greater Seattle area. To begin, let me first define acculturation and discrimination. Acculturation is the process by which an immigrant, when they move to the host country, adopts or rejects values and practices of the host culture, and at the same time retains or rejects the values and practices of their culture of origin. Discrimination is the everyday experience of mistreatment that is not specific to immigration. Anyone can experience discrimination. Now that we've defined that, let's move on to the rationale for the study. Asian Indians are a rapidly growing subgroup of the US population. Over the last 2 decades, the numbers have doubled. At this point, about 1.5% of the US population has an Asian Indian origin. King County has a much higher proportion of Asian Indians, essentially because of the tech industry. And at this point, about 14% of the King County population was born in India. We have limited research on the mental health of this population. The older adults in this population have typically immigrated at a later age. And so they have experienced the stress of immigration, the stress of acculturation, and maybe even discrimination as they move to a different culture at a later age, which may put them at a higher risk for depression. And all these factors that I mentioned have been shown to be associated with risk of depression in other immigrant populations, but we do not have evidence in this population. So understanding these unique drivers of clinical as well as subclinical depression in this population will provide cultural competence to treating clinicians and also may help formulate community-based or personalized interventions for depression. All right. So for this reason, I conducted the Community Resilience to Depression study. And the 2 main aims of the study was, one, to examine the association between acculturation and depressive symptom burden in the Asian Indian older adult population in the greater Seattle area. And the second aim was to examine the association between perceived discrimination and depressive symptom burden in this population. So this was a cross-sectional survey of 50 Asian Indian older adults. I obtained IRB approval and I got contacted with 2 Asian Indian community organizations. And I went and pitched my study at their monthly meetings. And those who were interested contacted me. I screened them, and if they were eligible for the study, I consented them. I first screened them, and then if they were eligible, consented them via Zoom, and then sent them the REDCap survey, which they could do at home. Participants had to be 65 years and older. They had to be first-generation immigrants from India who had become US citizens or permanent residents, and they had to have the capacity to speak and understand English and no diagnosis of dementia. At this point, about 31 participants have completed the survey, and so I will be presenting results based on the data from 31 participants. All the data was analyzed using SAS statistical software. Acculturation was measured using the validated Asian American multidimensional acculturation scale, which has 3 subscales to it. There is the subscale that measures acculturation to the culture of origin. There is 1 subscale that measures acculturation to the very broader Asian American culture. And then the last one measures acculturation to the mainstream European American culture. Discrimination was measured using the California Health Interview Survey discrimination module, which is 8 questions related to discrimination. And then depression was measured using the PHQ-8. This table shows you the baseline characteristics of the sample. This is a busy slide, but I've highlighted some values for us to look at. You can see that the mean age of the population was 75 years. And on an average, they had spent about 32 years in the US after immigration. And the most common reason for arrival to the US was to be with family. You can see that about 64.5% of them had come to be with family. The mean depression score was pretty low. It was about 2.3. The prevalence of any depression symptom was 16%. 13%, or 4 of them qualified as mild depression, and 1 of them had symptoms qualifying for moderate depression. This table shows you the results of the linear regression analysis that I did, testing associations between the acculturation subscores and the PHQ-8 scores. And you can see that there is no statistically significant association between any of the acculturation subscores and the PHQ-8 scores. I went ahead and categorized the acculturation score and into 4 groups based on what the acculturation scores showed. And this is based on a widely accepted model of acculturation called the Berry's model, which describes acculturation as a 2-dimensional process leading to 4 different outcomes. Immigrants could become integrated, which means they have high acculturation to both native and host culture. They could become assimilated, where they have high acculturation to the host culture, but low acculturation to native culture. They could become separated, where they have high acculturation, they retain the high acculturation to their native culture, but have low acculturation to the host culture, or marginalized, where they have low acculturation to both their native as well as the host culture. And you can see here that the group who are marginalized, which means they had low acculturation to both the mainstream American culture as well as the Indian culture, had a 3-point higher PHQ-8 score compared to the integrated group. And this was borderline statistically significant. This is the result of the association, test of association between the discrimination score and the PHQ-8 score. And you can see that this was statistically significant. For every 1 point higher discrimination score, the participant had a 0.54 higher PHQ-8 score. So in conclusion, the prevalence of depression in this sample population was 16%. Perceived discrimination was strongly associated with depression symptoms. Low acculturation to both the host culture and culture of origin was also associated with more depression symptoms, and this was borderline significant. Future directions of the study include completing recruitment and survey of 50 participants and doing a final analysis. I hope to do a larger survey with more power to establish independent associations controlling for confounding. Also hope to do longitudinal follow-up to test causal associations, because this is a cross-sectional study and we cannot establish causal associations or direction. That brings me to my personal narrative. My motivation to do the study is my background in epidemiology. My PhD training is in epidemiology. I'm also, as an immigrant, very interested in immigration-related mental health outcomes. My motivation for my career as a clinician scientist, I would ascribe it to just curiosity and the challenge of answering questions. I'm very fascinated with research methodology, and I strongly believe that every bit of rigorous research that we do will help a future patient. I am very thankful to the Garvey Institute and the Clinician Scientist Training Program for the funding to do the study. I've done other research on disability and dementia, but this is my first independent study on mental health outcomes in an immigrant population, and this really encourages me to pursue more immigration-related mental health research. I also want to thank my advisors, Dr. Tilke, Dr. Rao, and most importantly, the study participants and the 2 community organizations that I work with, the Mahatma Church of Greater Seattle and the Gujarati Cultural Society Senior Program. Thank you.
Thank you so much, Dr. Jacob, for that interesting presentation. I'd like to move on to our next set of presenters, Dr. Jackie Chipkin and Dr. Julia Ciar, mentored by Dr. Mac Black, and who's not able to join us today. But Jackie and Julia, take it away.
Hi everyone, thanks so much for coming. So Julie and I work together on a project about machine learning and specifically about using machine learning to develop algorithms that can screen patients admitted to the hospital who might be at risk of having a violent event or a behavioral emergency. And so, both of us as psychiatry residents do a lot of inpatient work, specifically at Harborview Medical Center, and kind of noticed and then did a literature review and learned about how kind of inpatient violence in a world and a healthcare system that is increasingly chaotic is becoming more common in the hospital, but we have very few methods to screen or proactive ways to prevent this. Inpatient violence can have negative effect on providers who are affected, getting physically injured, mental health consequences, higher burnout and turnover, and difficult retaining staff. Also negative effects on patients who have a behavioral emergency in the hospital might end up receiving antipsychotic medications by injection against their will. They might end up physically restrained. This might delay their medical care, and we know that these kind of outcomes disproportionately affect patients of color and vulnerable patients in our healthcare system. And so we really wanted to figure out how can we try to identify patients early who might be at risk of one of these events and prevent all of these bad things from happening. And a lot of the risk factors for who might become agitated or violent in the hospital, they're not really easily measured by numbers in a chart, but they're often well documented in clinical notes. And so we had the idea to use natural language processing, kind of like a computer that can read notes like a person, to pick up on some of these really complicated psychosocial variables, and really powerful in terms of its ability to screen patient populations quickly and automatically and on a pretty big scale.
Yeah, so in order to approach this, we built a data set of 280 unique code grays at Harborview Medical Center. A code gray is a behavioral code called upon a patient when we think they're at risk of being unsafe, whether towards themselves or towards our colleagues or other patients. From there, we had a pretty good set of 72 hours notes prior to a timestamp. So we wanted to have a psychiatrist expert baseline. So we had the psychiatrists go through these notes and say, yes or no, is this person at risk of having a code gray? At the same time, we developed a machine learning algorithm to also then do the same type of prediction. We trained the algorithm on 20% of the data set, and then we had it tested on the other 80%. And the goal was to then be able to kind of compare how did the psychiatrist do to the algorithm.
So here are some of our results, and we actually were able to recently publish these in Nature Mental Health, which was really exciting. We were able to calculate the F1 score for kind of each thing that we were testing. F1 scores are what's called a harmonic mean between precision and recall, which is a fancy way of just saying that it's kind of like the gold standard for measuring how well a machine learning algorithm can screen things. So it's the best kind of measure of how well it can predict without having too many false positives or missing too many false negatives. And so our psychiatrists had an F1 score of about 0.5, whereas our algorithm had an F1 score of 0.75, which is statistically significantly higher. You can see that this is represented by the graph on the right, which is what's called our ROC curve, or the way that you visualize the F1. So the dotted red line would be if screening was just left to random chance, and then the black line is our algorithm, and you want there to be more area under the curve catching more accurate patients. And you can see we have a pretty nice shape there that we're really happy with. And then finally, when our psychiatrists were reading the documents and deciding yes, no, I think this patient is going to have a behavioral emergency in the hospital, we also had our psychiatrists highlight specific words that we thought were risk factors. We kind of developed 8 categories of risk factors, things like people who are using substances, or a history of suicide, or a history of violence, or active psychotic symptoms. And you can kind of see an example of how we would annotate something on the left, and then trying to teach the computer to annotate the same thing on the right, so that ideally when we would run this algorithm in clinical practice, not only would it say, we think this patient is going to have a code gray, but it would also say kind of why and help us provide more evidence that then could guide intervention. So maybe the computer could read that a patient was withdrawing from opioids and needed an addiction medicine consult, but something really targeted and specific to help, again, prevent those bad outcomes and give patients the individualized care that they need.
Yeah, so there's a lot of different places like that are opened up because of this project. You know, what we're currently working on is expanding our data set, because in reality, it's not a one-to-one case control match, which is what we did with our initial project. That's not what our actual population looks like. So if we can get more case controls, it would better reflect our actual population. So we're working on that right now. Additionally, we're working on refining the outcomes of the F1 score with large language models, which is basically like ChatGPT. And what we're doing is having these large language models take the notes and kind of create a summary, and then using that summary to feed the algorithm to see if that produces a better outcome, because sometimes if there's too much language, it can make it kind of harder for the algorithm to make a prediction. You know, Jackie and I are both really passionate that if we're creating a tool like this, that we don't want it to cause more harm than good. So we're actively looking into the bias that's been encoded into the algorithm and thinking about how do we evaluate that, how do we quantify that, and then once we have a good understanding of that, like working on mitigating any risks that could come from that. We've tried, this is a pretty new area, so we've tried a few different things, and we're still really trying to figure out what this would look like, because it's really not been done before in this type of way. You can see the graph on our right is the race distribution from our initial paper. And, you know, I think that it's really important that we keep these things in mind as we create AI tools. Down the line, we have some people we've been talking to at different hospital systems regarding external validation. So seeing if this algorithm would work outside the UW system. Additionally, you know, we want to make sure that we're doing as much good with this as we can, and therefore thinking about how could we use this to predict restraint and seclusion use on the Harborview inpatient psychiatry units, as that has become a really big topic for kind of areas for improvement or areas to kind of evaluate.
So yeah, we just want to also thank the Garvey Institute for this funding and this opportunity. I know we both feel like it's really important data that we're researching and important people that we're helping, and also feel like personally and professionally this has been such a wonderful experience for us. I know for me, I think this project has really helped me understand that I really like working with people who are having a lot of kind of like acute crises, and figuring out how we can both prevent those and problem solve those better and more safely in the moment. It's one of the reasons I went into my addiction fellowship here, and also why I wanted to stay at UW, because I knew I'd be able to continue this research and have designated research time for it. And also why I've decided to stay at Harborview after I graduate and have accepted a job working in the emergency room as a psychiatrist. Have gotten to present at ACLP, which is our paper on the poster on the right, and we've also again published our paper, and so just really grateful for everything that this has given us.
Yeah, similar to what Jackie said, you know, this has just been a really awesome experience. I'm extremely thankful to the Garvey Institute to kind of expand my knowledge of research. I really had very little background. I mean, by little, I mean almost zero background in research. And this has really opened up a whole world for me. I really want to thank the computer scientists we work with. You can see their beautiful pictures here on the left. And that's Nick Dobbins and Avery Yu, who have been really wonderful. Working in like a nice big interdisciplinary team, it just has been like a really enriching experience. I really like proactive, preventive psychiatry, which is what initially drew me to this project. And it has really kind of opened my mind to what the research can be, and I've been very excited to be a part of it. So thank you.
Thank you so much, Jackie and Julia. And last but not least, we have Alexis Carnduff, who was mentored by Dr. Joseph Ciramelli, who is a faculty member now at University of Cincinnati, really rounding out a very, very diverse group of studies and very important studies. So Alexis, take it away.
Okay, well, thanks everybody for hanging in there. I know it is the lunch hour and it's Friday, and I love that a few of you are still hanging on. So hopefully I can keep your attention for at least the next 10 or so minutes. I'm going to be talking about my research project, which is titled Examining the Cross-Cultural Applicability of the Spanish Language PMQ-9, a Comparative Validation Study. All right, so a little bit of the overview. So I will start off by saying, much like Julia, I will confidently say I had zero research experience going into applying for this grant and working with the Garvey Institute, being paired with a mentor. And so it was really important for me to align with a clinical problem that I wanted to observe, and to understand the entire process of research from beginning to end. And I'm really excited that I was able to do that with the help of Dr. Ciramelli and Dr. Galindo, who I will talk about a little bit throughout the method section. So the clinical problem that I wanted to focus on was one, a psychiatric disorder that I find very, very interesting, which is bipolar disorder, with the caveat that manic symptoms are frequently underidentified, particularly in medically complex patients. There also is a really, really low likelihood that we'll be able to screen for mania in patients who are predominantly Spanish speaking, because there currently does not exist a screening tool for Spanish speaking manic patients. You can understand the situations in which this would become a problem, including diagnostic delays, suboptimal treatment, health inequities in Spanish-speaking populations. Dr. Ciramelli actually created what's called the Spanish language PMQ-9, which stands for the Patient Mania Questionnaire, very similar to the PHQ-9, except we do ask questions more along the lines of manic symptomatology. So, of course, we're asking about insomnia, irritability, overactivity, impulsivity, etc., symptoms that you would see within the bipolar population. And we really wanted to equivalate the Spanish language version of this and appropriately translate it and validate it, especially from a cultural context, into a Spanish language version. All right, so how did we do this? One, Dr. Ciramelli did have the PMQ-9 English version completely culturally validated, and there are a few research projects that he completed in succession of that. So once the English version was culturally validated, we essentially did the same process with a little bit more complexity for the Spanish language. So I had to apply for an IRB for the first time, which was very, very interesting. I had not had any interface with the IRB process and had to go through 2 different phases of IRB. I also had to find a research partner. And so 1, I partnered with Dr. Ciramelli as my mentor, and 2, we really wanted to involve somebody on our research team who primarily spoke Spanish as their first language. I grew up in a Spanish-speaking household, but that is not my first language. So we actually messaged the Hispano-American Special Interest Group of ACLP. His name is Dr. Jose Galindo, and he agreed to, 1, pair with us on this study, and 2, help us find a patient population. So he currently practices in Honduras and has a very intricate connection of both clinician connections and patient connections. So we were actually able to find a really diverse patient and clinician population in at least 5 to 6 countries in South America, which was really helpful for culturally validating this tool. So once we got our IRB in place and once we had our research team in place, we split up this particular study into 2 different phases. The first phase was taking a professionally translated PMQ-9 from English to Spanish through use of the Dynamic Language Services, who's based in Tacoma area in the Washington state. Once we had that professionally translated, we recruited over 70 Spanish-speaking clinicians amongst 4 or 5 different countries in South America. And this was more of a red cap survey where they provided some feedback on what wording they thought might be a little bit confusing for patients. Are there words that don't translate exactly the way that we think that they do? For example, there was a lot of feedback on a word discutir, which is basically to talk. And we really wanted to hone in on the fact that we're not talking about somebody being talkative, we're talking about somebody being overly communicative. And that was something that we really needed to iron out in terms of translation. Once we got the feedback from over 70 clinicians in multiple different countries, we made some slight adjustments based on that feedback and with the help of Dr. Galindo through our Spanish language PMQ9, and then we actually were able to interview 11 Spanish-speaking patients with bipolar disorder over Zoom. These were about 5 to 10-minute interviews where we showed them our edited PMQ9 in the Spanish language version, and then we had a script that we asked them as to how they felt filling out this survey, if they had any feedback on the way that words were used and whether that was confusing to them. Do they feel like this aligned with their experience of experiencing mania, et cetera, et cetera. Okay, so in terms of results, I gave away a few little things, but in phase 1, we had 71 clinicians. We really wanted to focus on how easy the tool was to use, willingness to recommend it to fellow providers, its overall helpfulness and cultural sensibility and acceptability rating, and some key feedback. I briefly touched on this, but what the takeaways I find important is about 87% found the survey easy to use, and almost half at 42.9 said that they would definitely recommend this to peers. 52.9 said probably, and that was one really important for us in that we knew right away that we had to make some tweaked adjustments so that we could get more people to definitely recommend. There was a rating scale of 1 to 5 with 4.21 of participants in phase 1 saying that they did find the measure helpful, and 4.1 saying that it was culturally sensitive and acceptable for use. Again, we really highlighted the nuanced cultural language that doesn't quite hit home how we want it to in the English language, and we participated in some minor revisions for clarity. For phase 2, like I mentioned, we did interview 11 patients. A majority of them were female, ages 30 to 65, but most were in the 30 to 35 age range. We were able to interview patients who lived in Honduras, Chile, Costa Rica, Panama, and Mexico, which was really important because what we found in the Spanish language PMQ9 and some suggestions is that there were also some ecological preferences, and that one word might be more common in Chile, and in Honduras, they never use that word. So it was really helpful to have multiple eyes on this to be able to say, yes, this is more of a universally used word, for example, nightmares instead of a bad dream. So some themes, because we did some qualitative coding, were understanding and clarity, cultural relevancy, interestingly, emotional response. There was a very wide variety in how patients interpreted using this survey. It was really, really validating for some patients. They were just beaming from ear to ear, saying that they wish that this was put into a very succinct checkbox for them a lot earlier in their treatment. Whereas other patients said that it was really distressing to see their recent experience with mania outlined on a piece of paper, and it brought up a lot of poor memories. There was, again, some suggestions and concerns regarding ambiguity in wording, similarity between response options, especially in different cultural settings, and then some patients offered some proposed modifications. So why did I take on this project? I think I really wanted to explore research for the first time. It wasn't very accessible to me where I went to medical school. If you wanted to be involved in research, you had to go to a summer training program at your very first year of your first didactic series. And I was just trying to survive my didactic area of medical school, so didn't really have time to explore other areas of what the medical field can offer. I was also really curious about a different side of academic medicine. I love teaching and I love education, and I was curious about how this looks like on another prong of what can be involved in academia. Like I mentioned at the beginning, I'm very, very passionate about bipolar disorder. I love inpatient treatment. It's something that I find extremely fascinating and wanted to understand a little bit more how it could bleed into the CL service side of things, and especially outpatient. I do come from a Spanish-speaking family, and I'm drawn to work that promotes linguistic and cultural inclusivity. So I am so grateful to the Garvey Institute. I'm so grateful to CSTP, to Dr. Ciarmelli, to Dr. Galindo. They were very, very patient with me when I asked a lot of clarifying questions, even in what acronyms meant, how the IRB process works. I truly was a first-time student in the area of research, and I feel a lot more confident in that I would be able to replicate something like this or possibly mentor somebody who wanted to be involved in an area like this. I feel like a little bit more sure of my footing and where I would at least point them if I was unsure. And I'm hoping to actually apply for a web fellowship in the ACLP world, and hoping that I can use my experience here to be able to fund another scholarly project, to be able to understand a little bit more and learn more about the CL space. Thanks for listening.
Okay, well, thank you so much for the wonderful, wonderful presentations. Thank you to your mentors for the great work. I just want to say from a personal standpoint, and I apologize, we don't have a lot of time for questions and answers, but I'm just, incredibly inspired by the energy and creativity of these presentations and our wonderful trainees, and personally very encouraged about the future of our field based on these. So I don't know, Jed, if we have time for one or two questions at all, or are we out of time?
We do have time. We've got about 4 minutes. That presentation was almost perfect. So if you guys want to jump back on here, we have one question here lined up in the queue. So I think, that'll work out great. We've got just enough time to answer this one question. So, a lot of you talked about this was, you having no experience at all with research before this. So the question we have here is, so have any of your perceptions of being a clinician scientist changed after doing your projects? And do you now think it's harder or easier to be a clinician scientist than you did before you were in this program? And I'll just open that up for anybody.
I can talk that. So I think I am in a unique position because I'm actually in the Montana track. So I'm at a rural community hospital. And I do think it's really interesting being here and seeing how much more limited access there is to research compared to being a part of the UW system. So I think it feels like it would be really hard to be a clinician scientist unless you really are in the academia world, which is kind of what Alexis is speaking to. Having said that, like doing this project as a part of UW has been really great and hasn't made me think it's necessarily difficult. It's just about a balancing act between clinical care and actually carving out the time to do the actual project. I have to hop off. I actually have a patient. So thank you, everyone.
All right. Bye. Thank you.
Anyone else want to chime in real quick about that? That's a great question, I thought.
For me, the chance to independently do my own study as like the principal investigator has given me a lot of confidence about doing studies in general. I have been doing research before, but it's mostly been secondary analysis. I have been co-PI on grants, but this is the first time I wrote, I funded, and I am taking a project to the end. So that is giving me a lot of confidence.
Yeah.
Yeah, I think I'd echo what Nini said. I mean, I come from like a lot of research background, so I think coming into this, I already had the expectation that being a clinician scientist was going to be really difficult. But my perspective was coming from a background of basic science research. So I was a lab bench scientist before this, and this project was the first clinical research project I did. So even though I don't know if I'd necessarily say that my perception of it being easier or harder has necessarily changed, but having gone through the process. You know, so many of the speakers today talked about the process of going through devising a clinical research project from start to finish and going through IRB approval and all of that. I think knowing all of those steps has put things in perspective for me. And, in some ways, I think having those concrete experiences makes it, the next project will always be easier.
Yeah. Great. Well, thank you all for being here today. That brings us to 1 o'clock. So I just want to say I really enjoyed having this large group today for our grand rounds and enjoyed meeting you all. So thanks for taking the time to do this.